My name is Shania Lee, and we are doing a review or analysis of the Anyone Who Had a Heart case study.
Patient analysis. Patient analysis. The patient is Jen. She's 37 years old. She's 28 weeks pregnant, and with twins. And she lives a very active work and lifestyle. Her history is that she's had a fertility procedure in the past. Her blood pressure is normal, and she has no diabetes. But because she is at an older age, she has higher risk for pregnancy effects, such as miscarriage, preeclampsia, and the initial issue is heart murmur, because the baby's had a 130 to 160 heart rate, and because she's older, she's at a higher risk for multiple pregnancies. She has been tested for diabetes and neural tube defects and has been cleared. It's recommended that she see the OBGYN weekly, and that there's a 9 in 10 chance that she will go into labor before full term.
All right, February 22nd, 2017, the patient has an emergency C-section. She has a male and female, as expected, both prematurely. The boy has normal vitals, has a normal heart rate, proper color, eating normally, but the female, she has blue fingertips and lips. She's suffering from poor circulation, high heart rate, and this is slightly alarming because it is very unusual for one of the children to suffer from cyanotic heart disease, which is what we're diagnosing this as, and the other child to not suffer from it. So that is a big concern.
The female patient, she has a deeper and faster breathing rate. It is confirmed that there's a heart murmur. She's very lethargic. Her blood pressure is 85 over 55, and her heart rate's still pretty fast. It's 160 per minute. And she's still showing signs of being cyanotic. Further tests are needed to determine final prognosis and location of murmur. But we're now putting her on 1 to 2 liters of oxygen per minute, checking her vitals and reassessing them. Pulse ox is 100, we're keeping it at that, and focusing on her motor sensory skills to make sure there's still brain function. Giving her a round of antibiotics, including indomethacin, and plan to perform ECG, CAD scan, and echocardiogram.
Alright, so the first possible diagnosis that we came up with was ventricle septal defect, and this is caused by a lack of oxygen being given to the lungs after the birth of a premature infant. Symptoms include a very fast heart rate, a decrease in feeding, poor weight gain due to the patient not having an appetite and not functioning normally. The second diagnosis was atrial septal defect, and this is a defect in the septum between the heart's 2 upper chambers. The symptoms for this, we found that the patient fit a lot more, which were cyanosis, which is what the initial complaint was, fast breathing, heart murmur, poor weight gain, as well as not eating.
February 26, 2017, the angiogram reveals that the patient's heart valves are normal. This rules out all prior possible diagnosis. The final diagnosis is the patient has patent ductus arteriosus due to the fetal blood vessels not closing as they should. Symptoms are harder breathing, slower heart rate, and because she's premature, she's at a higher risk than what's expected when she's not fully developed.
Alright, seeing that the final diagnosis is patent ductus arteriosus, we're sending the patient to PICU to undergo a round of antibiotics, including mostly including indomethacin for 4 to 7 days while she undergoes observation and being assessed. If she shows no improvement within the 4 to 7 day period, because she is premature and very young, she's at a higher rate of dying pretty much. So if she shows no improvement, open heart surgery will be required.